Welcome to Voices of the Community, which explores critical issues facing Northern California communities. We introduce you to the voices of community thought leaders and change makers who are working on solutions that face our fellow individual community members, neighborhoods, cities, and our region. This is George Koster, your host. This episode is part of our series exploring COVID-19's impact on nonprofits and small businesses in the San Francisco Bay Area. Back in April of 2020, when we decided to create this ongoing series on COVID-19's impact, first on nonprofits and then on small businesses in the San Francisco Bay Area, we, like you, had no idea how long the pandemic would go on and what the health and economic impact would be in our community. With vaccinations increasing, COVID-19 cases and deaths decreasing, we're now moving into the summer of 2021 with the reopening of the economy and all of the uncertainty of our ever-changing indoor and outdoor, vaccinated and unvaccinated protocols, and the politics that will drive how we all come back together as a unified or fractured community. We will continue to shine a spotlight on the nonprofits and small businesses that make up the fabric of our community, along with the founders and staff who are struggling to deal with the impact of the COVID-19 pandemic on their operations, services, and sustainability until we can all get to the other side of the pandemic. Along the way, we will also share with you all the amazing solutions that our nonprofits, small businesses, foundations, and government leaders are working on to help us all get to the other side of the pandemic and come together to rebuild our communities with more economic, social, and environmental equality.
I think the energy devoted to treating mental health and reaching people who have mental health conditions is going to be on fire for not just this year, but for a while, because we don't know exactly how deeply this pandemic and the mental health conditions that came out of it, we don't know how long it's going to affect people yet. We just know it has impacted people and it will be for some time, but we don't know how long. So people are going to be in there and trying to offer services for a while on the federal level, on the state level, on the city and county level.
This is mental health service expert Jennifer Baity. According to an April 2021 study by the Kaiser Family Foundation, 55% of women and 38% of men say that the pandemic has negatively affected their mental health. The pandemic has impacted our younger community members ranging from age 18 to 29 years old of age, with 69% of women and 54% of men reporting a negative impact on their mental health. I am joined remotely by Jennifer Baity. Jennifer is currently a therapist in private practice who does training on motivational interviewing and other topics for various agencies throughout the Bay Area and beyond. She also does clinical consultation and supervision. Previously, she worked as a program director of the San Francisco Mental Health Rehabilitation Center, where she worked from 2000 until February of this year, 2021. Jennifer, welcome to the show.
Thank you. I'm so glad to be here.
So I'd love to begin by having you provide the audience just an overview of your background. I read a little bit of it, but you've been at this for a while in mental health services.
Absolutely. I will actually start back in college. When I was in college, I had a wonderful practice professor in graduate school. And he basically said, if you're going to be a social worker, you can do so many different things. And that was one of the things that attracted me to this kind of career. And that has been so true for me. My professor said, first he worked with elderly blind people, and then he worked in an after-school program, and then he worked here, and then he worked there, and in Palissy and wherever. And that has absolutely been true for me. So my own experience was, after graduating in 1994, I started working for Seneca Center, and I worked in their therapeutic foster care program. I did that for a couple of years. And then I worked for their school-based program, working with kids who had severe emotional and behavioral problems, so they couldn't be in public school. So I was a school-based therapist in that program. And then I worked for their training department over at Seneca Center. They're now called Seneca Family of Agencies. They're humongous now. They were tiny when I worked for them way back then. And then I worked for Edgewood Center here in San Francisco. This was before Seneca had a San Francisco program. That's how long ago it was. And so I worked for some of their school-based services. I worked at Bessie Carmichael Elementary School graduates. I worked doing some services in that elementary school. For the last 20 years, up until February of this year, I worked at a program on the campus of San Francisco General Hospital called the Mental Health Rehabilitation Center. It went through a couple of different names. A lot of people still know it as the MRF, the Mental Health Rehabilitation Facility, which it was for the first, say, 5 years or so it was open. But it's the MRC now. It's the Mental Health Rehabilitation Center.
And who were the clients, if you will, of that center?
Sure. The clients there are largely clients with schizophrenia spectrum disorders, but not all. Some clients also have severe intractable bipolar disorder or depression. It's a subacute care locked facility. After you've come out of a facility that's more acute, like say 7B or 7C at San Francisco General, or the acute care facility at St. Francis or someplace like that, you might be referred to a facility like the Merck. Your team felt that you needed a longer term stabilization before it would be optimal for you to be discharged into a community program that was unlocked. So if you needed more time skill building, like how to cope with your voices or how to cope with your moods, or if you weren't great about taking your medication every day and so needed coaching around. That was what our program was for, and so much more. But that's the basics right there.
One of the reasons I wanted to have you on the show, besides being a longtime friend, is you've been working in mental health for a really long time. And here we've had a global pandemic. And I would love to get your insights into how COVID-19 has not only impacted where you were working, but also mental health services in general here in San Francisco. And as we know so well, nationally.
The whole country, the whole world was thrown for a loop when this hit because, say, in the program where I was working, we had been used to doing milieu therapy. We did groups. Of course, no one wore a mask. We weren't worried about things like that. And then suddenly, we were hit with COVID-19. And given that we were on the campus of San Francisco General, it was a blessing to be on that campus, to be, where you were getting the hottest off the press news about how to keep safe during the COVID-19 pandemic, right? And so as soon as the pandemic, my team, it was myself and my supervisor, who was the supervisor for the whole building. There's a couple of other programs in that building. And so it was myself and my boss and like 4 or 5 other managers, basically. And we started having a daily meeting about, okay, what do we need to do today? How can we support our staff today? What policies do we need to implement today? And then get all of that information out to our staff. And then our staff and us, along with management, how do we communicate this to the clients in such a way that the clients aren't terrified to death? Because one of the things we had to do immediately was cancel groups, because most of our groups were in smaller rooms where you couldn't really social distance well in those rooms. And so that made it very difficult for us to do more than a few groups here and there. Like we had to move groups to the dining room area, or we had a large activity room. But that left a couple of rooms that we used really regularly for groups completely unused. And clients going, how come we can't do this group anymore? And how come we can't do that group anymore? And how come we can't do this other group anymore? And us going, we really want to do them too. We enjoy doing those groups. One of the groups that I used to do, or 2 of the groups that I used to do, I couldn't do because there wasn't time to fit that into the schedule along with what my team members were also doing. And so we had to kind of triage what is most important in terms of what services are most important that our clients receive, what is required by, say Title IX, which oversaw us in our facility. What can we safely do? What do our clients want? So we're always balancing what do they want, what do they need, because we can't just provide what they need without also providing some things that they just enjoy. So that's part of it. We had to cancel passes outside the building, which we always did. So we had to cancel passes where we'd take clients out on van rides out to Pier 39 or out to Ocean Beach or to the zoo, things like that, which, was part of our recreation program. It's also part of our community integration program. We would take people to the museum. We would take people to the ball game. And we couldn't do any of that during the entire part of the pandemic when things got shut down. And that impacts how people feel psychiatrically and psychologically. And so people's symptoms got worse, not better in a lot of cases. And so we had people hospitalized for longer periods of time than for shorter periods of time. And it was just because we couldn't provide the kinds of things that would make them better. We couldn't allow them to go outside because it wasn't allowed, and then all the testing and the screening that we had to do all the time. Even if we had 100 and some staff in the building and we had 100 and some clients in the building, even if one person might have a symptom, we're like, so-and-so has a runny nose. We think it might possibly be this. Then we had to test that person for a period of time. And then we had to test everyone around them. And nobody likes to be tested, especially, psychiatric clients. It's invasive. And I don't know if you've had COVID testing, George, but, when you have that little thing stuck up your nose, it's really painful, right? And so to have that done to you in an involuntary care setting, it doesn't build relationship with your care providers. Is what I'm saying there.
That's good observation.
Didn't make the clients happy. Here she is with the prong, and so the poor RNs were just trying to do their job, or our nurse practitioner was just trying to do her job. And they're the sweetest people alive. And sometimes we'd have clients that we really need you to do this. And so we would have their nurse practitioner and their nurse and their therapist and their OT and their psychiatrist would all try at different times, gently, nicely to try and, talk them into doing these things. And it was just a lot of challenges like that. And even vaccination was a challenge, obviously, as it is across the United States. There's some people that are like, absolutely, give me the vax right now. And some people who are like, no, thank you. I don't want that thing, even if I hear it'll keep me safe. So there was just a lot of those things that all contributed to changing the quality of care. And it's not just in our facility, I'll just say. This was not unique to us. This was any type of community or congregate care type of facility. This type of thing happened at, say, a nursing home that provided activities. This happened in acute care. They had to cut back on the kind of groups that they were doing. This happened in outpatient settings. This happened in inpatient settings. It cut across mental health services across the United States and beyond. So knowing that it was a shared experience made it better in some ways, because you could Google, you're like, okay, what are they doing? What are they doing? The Merck that I used to work for is the only city-run mental health rehabilitation center, a city and county run one of these. But there are some nonprofit ones run around the state of California, run by, say, Crestwood Center and other facilities like that. And so I remember at one point going, what are they doing? Are they doing anything differently than we are? I want to make sure that even though this is what I'm doing and this is what I'm being told, is there something else that I can be doing for clients that I just missed? And they're like, no, we're doing the same thing that you are. I'm like, okay, because I just wanted to make sure that I wasn't missing some extra service I could legally be allowed to provide my clients that I wasn't providing. But we're all stuck providing a limited version of the services that we used to provide. And a lot of those services had to be provided one by one by the LCSWs and the MFTs that I had working for me, the ones that I supervised, as well as the activity leaders and people like that who were unlicensed, but providing a lot of the day-to-day activities, like they would open up the activity room so the clients could use computers and things like that.
So over the many years that you worked at Murph, what would you say is some of the biggest impacts it's had on mental health service providers, but on the community of San Francisco at large?
I'm glad you asked me that question, because I think there's a lot of people who don't really understand how this facility fits in to the rest of mental health services in San Francisco. Really, there's nothing that's going to stop the revolving door of clients that have very severe psychiatric conditions periodically, because these are chronic conditions where people do have relapses from time to time. If you have a condition like schizophrenia or bipolar disorder or a severe substance use disorder along with that, you can expect that every once in a while somebody's going to stop taking their medication, or their medication's going to poop out and, they're going to have a recurrence of symptoms. And so they're sometimes going to need to be rehospitalized. And so there is going to somewhat be a revolving door where people are going to be in the community for a while, they're going to be doing well, and then there's going to be a little flare-up of symptoms like you have with any other kind of medical illness, like you might have with a cardiac illness or diabetes or anything else. So if you didn't have this level of care, what would happen is people would go to psych emergency, and if they needed longer term care than that, they would go to the acute care units upstairs at General, for example. They'd maybe go up to 7B. They would stabilize a bit. They would go to 7C, which is the less acute unit than 7B there. And then if they were stable enough from there, they would go back into the community. And for most people, that system alone works just fine. But there's a subset of clients that never works fine for, that when they get destabilized, they need longer term stabilization than is reasonable for an acute care unit to provide. And so what happens is, if you're put in an acute care unit and you don't meet what's called medical necessity, it's like basically what your insurance company will pay for. If you're not like super psychiatrically ill and you're on an acute care unit, they're going to reimburse your care at a really low rate. And so it's the facility itself that ends up bearing the cost for a lot of the care. And so they want to get you to a place where it makes more sense for you to be, instead of taking up their expensive bed where somebody else actually could benefit, because definitely there's people out there that could use that bed. So places like the MERC, the Mental Health Rehabilitation Center, were created for this reason. If you have somebody who needs longer term stabilization, you send them to a subacute place where they can get longer term stabilization. They can build more skills. You can work on whatever the thing is or the things are that they need before they could go, say, live with their mom or live in their own apartment or live in unlocked residential treatment or wherever it is that they need to go next. Because if they went right there, they would probably not be able to stay very long because their symptoms would flare up or they might go get high. My background is I'm a licensed clinical social worker, and I'm also a licensed advanced alcohol and drug counselor. And so when I was initially hired there, I was hired as the co-occurring disorders specialist. So a lot of our services there were integrated. And so we weren't just helping people with their mental health conditions. We were helping people with their substance use disorders on top of their mental health conditions and helping them see that, like, if you don't treat the one, it's going to be really hard to manage the other. So we did groups for both things. We did individual counseling for both things. The psychiatrists treated people for both things and would provide medications for both things. We provide medication-assisted treatment and, gave people Narcan when they were leaving and all that kind of thing. So, make sure we were treating the whole person. So basically, we were saving the system money is one thing. We're also making sure that the clients were getting the best possible care by allowing them to have the time for rehabilitation that they needed.
So now you've segued out of MRF and you're out on your own. Could you share a little bit about what you're doing these days? And then the follow-on to that would be, how can people get engaged with you?
Sure. My segue out is hard for me because I worked there for 20 and a half years. And I loved that place. I love my clients there. I still want to go back and be like, how are the clients doing? I can't do that because of HIPAA, but I still want to know how each and every client that I worked with there is doing. I mean, I still want to know how my foster kids from the 90s are doing. It's just how I roll. So for me, it was hard to let go. It's like I let go with fingernails attached. But I spent a lot of time during the pandemic, as I think a lot of people did, doing some reevaluation about, well, is this what I want to keep doing forever, or is this time for me to do something else? And I really was starting to think that I wanted to get back into doing more direct service work since I had been doing more management work. I was doing clinical supervision, I ran my groups and everything, but it wasn't enough one-to-one for me. And so I missed that so much. I really missed, seeing people in single session, one-to-one, and saying, what's going on for you and how can I be helpful to you? So in February, I decided to go into private practice, and I'm still running my training business on the side, which I've been doing for 20 years plus. And that's my life now. I work for myself. I'm my own boss, and I've never been my own boss in my whole life. And so, I was kind of like, oh, how's that going to go? But that's been going great. So how can people get in touch with me? I have a website. So www.jenniferbaity.com. I know you're going to have a link to it probably somewhere on the webpage because my last name is hard to spell. It's like the word bait with a Y at the end. So, if you want to get in touch with me, if you are seeking counseling for, anxiety or depression or PTSD or something like that, or substance use or some combination of all of that, I am seeing a small number of clients in my private practice. And again, I love training people at large agencies and small agencies on different topics.
I was just going to say, tell the audience a little bit more about your training piece as well.
So for the last 20 years, I've been doing trainings at different agencies. It started when I left Seneca as a clinician. I started doing little 2-hour trainings for them on substance use at each of their programs. And that turned into a 15-hour pre-licensure class on substance use disorders. If you're going to be a licensed marriage and family therapist or a licensed clinical social worker or an LPCC, you have to have a minimum of 15 hours in training in this area. So one of the folks that ran the training department at the time was like, well, you develop a training like that. And I was like, okay, that sounds like that would be easy for me to do. Okay, just put some PowerPoint slides together, follow these guidelines. I can do that. And of course, it scared me because it was new and it was longer. But once I put it together, I was like, I like doing this. This is fun. So I put that one together, and then I put another one together in another area, and another one together in another area. And then when I started working for the Merck, I got hired as the co-occurring disorders specialist. And so one of the things I was trained in almost immediately upon working there was I was lucky enough to get trained by Dr. William Miller and one of his colleagues down at the University of New Mexico in motivational interviewing. And it changed my life. I can't even tell you. It's like, if you're not familiar with it, it's a very, very useful clinical method of helping people who aren't necessarily, they're ambivalent about change, but it helps them to get less ambivalent about making a positive change in their life. So if somebody say, oh, maybe they're binge drinking and it doesn't cause a lot of problems most of the time, but it's causing major problems, say at home, or they binge drink on Sunday night. Maybe they don't show up to work on Monday morning. And so it's having a low key clinical conversation with somebody about it where I'm not trying to high pressure sales them into being like, well, you need to stop binge drinking, but instead just having them evaluate what do they think about it? What do they think the pros are? What do they think the cons are? What do they think the pros might be of making a change in that behavior? What do they think the drawbacks in making a change in that behavior might be? And then basically helping them come to their own decision about it through a lot of Socratic questioning, reflective listening, which helps them feel really supported through the process. Because, for me, I don't think it should be up to me to decide what somebody should do with their life. So it really fits with my personality. It's like, I shouldn't be pushing somebody to do something. Somebody should want to do the thing. And so I teach how to do that kind of counseling. There's some other counseling styles that I teach as well. I teach people about schizophrenia and bipolar disorder and things like that. So basically, I've worked in this field a long time. I have a bunch of trainings that are already developed and that are up on my website. But if there's something specific that somebody would want training on, I'm also very happy to develop that for them.
Thank you. It was great. I've never heard the whole story of all of your training and the many decades of working on it. Speaking of many decades of working in this space, could you share with the audience perhaps one of your favorite stories?
Sure. It's so hard when you ask for like one of the favorite stories because it's always like there's never one. I think back to a client that I worked with at Seneca back when I was a brand new social worker, a kid that I worked with who came from just this horrific traumatic background, who you would predict would have just a horrific life trajectory. But, instead, while we worked with him, went on to like make it as the star basketball player on his team, was in the newspaper, and you're just like, that's just such a wonderful, wonderful moment to be this kid's therapist and social worker. So that's like a moment. I've had clients like this at my most recent job at the Merck. And I have a client like this right now in my private practice. So it doesn't matter if I'm working with somebody who has schizophrenia, who's working on their substance use, or if I have a client like in my private practice. I was working with a client very recently in my private practice. She is trying to cut back on different aspects of her drug use. So I'm working with her on a harm reduction plan. And she was going to this 9-hour party and there was going to be tons of cocaine there. And she didn't want to use cocaine. And she knew that it was going to be extraordinarily difficult for her not to do it because, that was a thing that she really enjoyed doing. So we came up with this plan where she was like bringing a friend with her. She was going to allow herself to drink alcohol, but she had a limit. If she really wanted to get like that stimulant buzz, she brought a Red Bull with her. So when her boyfriend went off to, go use Coke at the party, she was like, I have a plan. It's fine. I'm going to go hang out with my friend. I'm going to chug my Red Bull. And she did that. And, she occupied herself with other things that we had talked about doing. And anyway, it went perfectly for her, bottom line. It's always so exciting to me. It's like client has a goal. We come up with a plan. Client achieves goals. It's like, for me, it's always just that. It's helping people do the things they want to do. On the training side, about 15 years ago, when I was just starting to kind of make a name for myself doing these kinds of trainings, and not very well known in DPH at all, Department of Public Health, and they hired me to do a training for 200 therapists who work for the Department of Public Health. And I forget the exact title, but it was basically something like what every therapist needs to know about drugs and alcohol in order to do their work is like drugs and alcohol 101 kind of a thing. And to be able to do that was one of my goals. And I was out there looking at this sea of 200 therapists who mostly knew about mental health and not a lot about substance use. That's something I always wanted to do. And I got to do that. And I was like, yes, that felt really good. It felt good to be able to fill that knowledge gap for some people. And that's one of the things I like about training. Like I was doing a training recently, opioid use disorder. And, one of the things that I think a lot of people don't seem to fully understand is that medication assisted therapy, being on buprenorphine or being on methadone really, really helps. That most people who don't receive that relapse very quickly. And sometimes their relapses are more likely to be fatal if they're not on medication-assisted treatment. So there's a lot of people who, if you're more closely on the substance use side of things, who understand those things. But if you're more in mental health world and you don't see a lot of clients who are addicted to opioids, you don't necessarily have that understanding. And if you're only, again, required to have 15 hours of training in substance use disorders to become a therapist, you can understand why that disparity might be there. So anyway, I'm doing this training on opioid use disorder, and I'm explaining that, this is a thing. And you could just see like light bulbs go off for people, and people were asking me questions about it. And I'm like, yeah, this research says this and this research says that about it. And that kind of thing just lights me up because I'm like, these people are now going to help their clients harder to get on MAT than they would have before.
Thank you. Those are all really great, both stories and examples of mental health services and treatment and the training of others. All really great stuff. So final question to wrap up. What do you feel are some of the positive things that could come out of the pandemic and all of its subsequent meltdown on multiple fronts that could really help us in providing more mental health services to our community?
Yeah, well, I think one thing, it's kind of one of those bad news, good news things. So, we've experienced the global pandemic, which caused so many more people to have mental health symptoms. I read something recently that said that like 42% of Americans experienced symptoms of anxiety and depression as of December 2020, which was double what it was in the year before. So that's how bad it has been. And so twice as many people now, they've either experienced those symptoms or they know someone who has. So they're friends with those people, they're family members, they're work colleagues. And I think people are also being more vocal about it because it's more prevalent. And they're also more, they're more open about asking for services and asking for what they need because it's like, hey, it's a more universal phenomenon. So recognizing the symptoms is one, asking for help is another. So I think there's a little bit less stigma than before. There's still stigma, but a little bit less stigma than before because more people have experienced it. I think another thing is because people couldn't leave their homes and couldn't meet in person for therapy during the pandemic, there's a wider acceptance of teletherapy, which, people have been trying to roll out teletherapy in this sort of awkward way, like, please accept teletherapy as an option. Really, you'll enjoy it. And people are like, no, I'd rather go in person. But, the pandemic made people accept it. They had to. There was no other way. And so once people started using it, they were like, oh, I kind of like it this way. In fact, I saw a brand new client this morning, and when he found me on Psychology Today, he didn't realize at first that I only saw clients using teletherapy. And he was kind of like, oh, well, I guess it's okay. But then I saw him this morning for our first real session. He's like, oh, I wasn't sure I was going to like it this way, but it's fine. It's just kind of the same as seeing somebody live. It's like, as long as you can communicate it, he felt that we would feel distanced, but we didn't feel distanced. So people's preconceptions about teletherapy sometimes turn out not to be true. I'm not going to tell you that there isn't something that's lost when you don't see people in person. There absolutely is. I can't see people's entire bodies and they can't see my entire body. And you miss that little being able to shake hands with people when they come in and offer them a cup of tea. And I'd love to do things like that, when I've seen people in person. There are things that are lost, but there's also things that are gained. People don't have to drive an hour and a half across town in rush hour traffic to see me. And just all that mess, if all they can do when they're feeling really awful in the morning is open up their laptop and click on the link to see their therapist, that's a huge gain. That's a huge gain because sometimes that's all people feel like they can do. So that's a gain. I think the energy devoted to treating mental health and reaching people who have mental health conditions is going to be on fire for not just this year, but for a while, because we don't know exactly how deeply this pandemic and the mental health conditions that came out of it, we don't know how long it's going to affect people yet. We just know it has impacted people and it will be for some time, but we don't know how long. So people are going to be in there and trying to offer services for a while on the federal level, on the state level, on the city and county level, on your business. You know, if you have a mental health entity, they are going to be paying closer attention to surveying everybody anonymously. How is our staff doing? You know, and those are going to be anonymous surveys, but they're going to be taking mental health surveys to see how is our staff doing? Are they experiencing a lot of anxiety and depression? What should we be doing about that? So they're going to be paying attention. Our corporate overlords are going to have to be paying attention because otherwise there's not going to be staff to staff those corporations. I think part of what we're seeing when employers are complaining about, oh, we're not able to hire people, people don't want to come back after the pandemic, you know, it's a lot of things, but I think partially it's mental health. And I don't think there's a lot of recognition that part of it's mental health, that people are making very careful decisions about which job to go back to and why and what they can put up with, not just what they're willing to put up with, but what they are able to put up with based on how fragile their mental health is right now. So they can't put up with what they used to put up with necessarily. It's not just that they don't want to. You know, they might have a child who's suffering from an anxiety disorder right now that they didn't last year. So I think as a country, as a whole, we have to be paying attention to this. Also, mental health equity. I think health equity is something that the country as a whole is paying closer attention to. I think we saw how poorly, just writ large, the pandemic showed us, you know, more people dying, people of color, poor people, Black people, Latinos, you know, people who generally have less access to health care. And these are also people who have less access to mental health care, who have less access to people who look like them. We don't have language. Let's say that you speak Mandarin. Good luck finding a provider right now, you know, and you need to have a provider that speaks Mandarin. I'm sorry, but you do. And I can't do it. You know, even if I have a translator, I can't provide good services in Mandarin. It's just super awkward. Even if I was working at the hospital and I had somebody on staff who would be providing good translation next to me, it is just not the same as having somebody who is culturally and linguistically able to provide those services, who is a licensed mental health provider. And we need to recruit and train and have all of those. We need to do better, bottom line. So that's part of what I hope will come out of this as well.
Thank you. All really wonderful insights. So thank you, Jennifer, for sharing both your insights into our mental health services and your own mental health practice today. We'll make sure that listeners have your contact information, website, social media, so they can follow you and get engaged in your mental health services. Please stay safe and healthy as we all work our way through this very strange new normal.
Thank you. So nice talking with you.
That's it for this episode of Voices of the Community. You've been listening to the voice of Jennifer Baity, a therapist in private practice who does training on motivational interviewing and other topics for various agencies throughout the Bay Area and beyond. To find out more about Jennifer and the mental health services that she provides, please go to jenniferbaity.com. Jennifer had mentioned her work with Edgewood, and you can find out more about Edgewood Center for Children and Families and their work with teenagers in our interview with Justine Underhill and Greg Biggs in episode 32. Please tune in to KSFP 102.5 FM to next week's show on July 8th at 8:30 a.m., where we share the voices of the San Francisco Radio Club about the 100-plus-year-old club of amateur radio enthusiasts and the Bayview Opera House about their neighborhood-centric support during the pandemic and how they are reopening and hosting live performances. We hope that you enjoyed the insights, points of view, and personal stories from the voices of changemakers and their nonprofits and small businesses featured in this series. To find out more and get engaged with the nonprofits, small businesses, and staff members featured in the series, please go to my website, georgecoster.com and click on Voices of the Community to find links to the extended versions of these interviews and to listen to the entire series. After listening to these stories, we hope that you will consider making a donation and volunteering to provide a hand up to your fellow community members. I want to thank my associate producer, Eric Estrada, and Casey Nance at Citron Studios, along with the wonderful crew at the San Francisco Public Press and KSFP. Voices of the Community is a member of Intersection for the Arts, which allows us to offer you a tax deduction for your contributions. Please go to georgecoster.com and click on the donate link to make a donation to help us provide future shows just like this one. While you're on our website, you can enjoy our archived past shows, which feature community voices working on solutions to critical issues facing Northern California communities. And you can sign up for our newsletter to find out more about future shows, as well as shows and events from the organizations that are included in our episodes. Take us along on your next COVID walk by subscribing to Voices of the Community on Apple Podcast, Spotify, and Google Podcast, or wherever you get your podcast. You can follow us on Twitter at George Coster, and we'd love to hear from you with feedback and show ideas, so send us an email to george@georgecoster.com. I'm George Coster in San Francisco, and thank you for listening.